Top Med Talk. So hi, I'm Monty Mythen, Editor-in-Chief of Top Med Talk. Welcome back to the conference being held currently in Orlando in Florida, USA by Duke University Medical Center entitled Controversies in Perioperative Medicine. So I'm here with Mike Grocott, who's one of the visiting faculty from the University of Southampton in the United Kingdom, but also part of the Morpheus Consortium. Hey Mike, how are you? Good to have you back.
Good to be here.
What's the Morpheus Consortium?
So the Morpheus Consortium is a group of currently 3, it was 2, institutions who have a passion for improving perioperative care. So originally established between UCL in London and Duke in North Carolina. They very kindly engaged with Southampton on the south coast of England, where I come from. It's all about improving perioperative care through education, research, and influencing policy.
Excellent. And we've got 2 other guests with us today, both from Duke University Medical Center. We've got Annemarie Thompson and Padma Gulur, who's been with us before. Padma, welcome back.
Thank you.
So Annemarie, you're new to Top Med Talk.
Yeah,
Welcome.
This could go south, Monty.
So we've been having a great meeting here, day 2, and this morning we were dealing with some big picture issues, things where we have opportunities to make a real difference to our patients here and now. A lot of things we can discuss are highly speculative. But if we start with our old friend pain management, and in particular where we stand with regards to opioids, Padma, we've interviewed you before relatively recently about the so-called opioid crisis. And within that, we've been recognising our possible contribution as opioid prescribers to the fact that some of these drugs can leak into the community, and perhaps we're helping some people inadvertently to become addicts. Now, as part of accepting responsibility for our relative contribution, we've been discussing pain as the 5th vital sign, and whether we went a bit overboard with that. And you referred to that in your talk. Do you know this sort of obsession with making all pain go away post-operatively, and the belief that somehow that an opiate is the only thing that can really fix bad pain?
It's been quite a journey. I mean, back in the 90s, there was a time when we were not treating pain adequately, and that caused a lot of people to start a movement really to say that pain needs to be treated more appropriately. Pain as the 5th vital sign is a bit of a misnomer, because people believe that the Joint Commission instituted that as part of its accreditation of hospitals to make it the 5th vital sign. If you go to their website now, they actually have a detailed page denying that claim, or that claim to fame,
right,
and stating that they had never quite asked for that to happen. Now, it's controversial. There are different people who feel differently about that. But more importantly, their goal was to advocate for pain management.
Yes. What
was an unintended consequence is that pain management started to equal opioids or opiate management. And to the exclusion of all else, we started to prescribe opioids to manage this pain without adequate support, without adequate education around multimodal techniques, etc. And that has led to the prescription drug abuse epidemic that we're currently facing here in the United States.
So Annemarie, from your perspective, what did you feel as though you were under pressure to perhaps oversubscribe pain meds at one stage?
I remember during my internal medicine training, what was remarkable was the pain, the 5th vital sign sort of moniker came out. And that was, what it basically did is it supplanted what I believe is truly the 5th vital sign, which is oxygen saturation. You have blood pressure, heart rate, respiratory rate, temperature. Your 5th vital sign should be oxygen saturation. And I would say, tragically, that was supplanted by the idea that pain is your 5th vital sign. I distinctly remember that coming out during my training in the 90s, and the emphasis that was placed on doing that as a measurable outcome that hospitals were judged by. Interestingly, I would say both as internists, as an internist and as an anesthesiologist, I think everyone, not just anesthesiologists, has contributed to this current crisis. This was, at least by some organizations, considered to be a medical imperative, that we treat pain and that any pain score above 0 was unacceptable. So I do feel, just as a physician, regardless of the specialty, we have all probably in part been unwitting participants or contributors to this crisis.
Now, in medicine, we, over the decades, over the centuries, we have this tendency for the pendulum to swing right one way and then swing back the other way. We've seen that with fluid management. We went from drowning. More recently, we've gone to desiccation, and we've seen harm associated with that. So I don't in any way, shape or form anyone's saying we shouldn't treat pain.
Right.
And we should make patients comfortable, should be the objective. But Mike, in the UK, do you think we had a similar journey, and what have we done about it?
I think we probably were a little bit more moderate. I mean, clearly the alleviation of suffering is one of our core professional obligations, and I think so. My impression was that the pain as a fifth vital sign thing we heard, but was not fully adopted. What it did do was it made it easier to not think too much about prescribing pain medications. And as Padma rightly says, the unintended consequence of that was potentially over-prescribing.
We got into fixing the pain score, though, didn't we? We started to become obsessed, I believe, with having good-looking pain scores rather than functional pain relief. Is that fair?
We did, and given that pain is subjective and therefore in itself rather limited as a vital sign, given all the other vital signs are measurable and objective, and it's also therefore very hard to measure. That was probably a mistake in the first place, and then a road that we continued to travel, causing harm, sadly.
So, Padma, you told us more about optimal pain management, and there's been a movement around the world now to have more functional pain scores, so to combine the ability to mobilise, for example, with comfort measures as opposed to the obsession with the pain score. Is that where you're going at Duke?
Absolutely. I think, setting expectations, I think more than even just the score, it was the expectations we were setting amongst the patients and the providers. When we said pain is the fifth vital sign, I think we started to send the message that you should experience no pain. I mean, it was less about the number, more about the fact that we were, by asking patients repeatedly about their pain, we made it seem like they shouldn't have any, as opposed to educating them appropriately that this is what we would consider appropriate as long as you're functioning. We really want to just manage your pain.
And the post-operative period for most patients having in-hospital surgeries, for most patients there is some degree of pain through to really quite severe pain associated with that. And in treating that, the opiate is just one of a very, very many large number of tools. And I think you divided into three broad categories of things we should consider to try and help patients, both psychological, medical, I think there's a physical. So it's not just the tablets and the meds, is it?
Oh, absolutely. The story is much larger. It takes a lot to manage pain, and focus it only on pharmacology, and that too on a small number of drugs or one class of drugs, is really where we fell short over the last few years. And making sure that and pain by itself, is hard to measure, as Mike just pointed out. It's assessment is challenging because basically we don't have objective measurements. And pain means different things to different people. There's also suffering, the component of suffering, hence the psychological aspects of this and helping manage it. Two people can have the same injury and experience pain differently for the same injury. And we have to recognize that and accept that.
So, Padma, so you're a pain specialist. So Annemarie, if I was to ask you what sort of specialist you would describe yourself as primarily, what would it be?
It would be a cardiothoracic anesthesiologist.
Okay, so those ops, if you have a bypass and you have an open chest, for example, or thoracic procedure, they hurt a lot.
They do. And it's not simply incisional pain. There's a lot of referred pain. So I work in the cardiothoracic ICU, so patients coming after thoracotomy will often not complain as much about the incisional pain, but especially if they have an epidural for pain control, but they'll complain of shoulder pain, which isn't covered by an epidural, which speaks to Dr. Gulur's point that expectation management is very important in these patients.
So your expertise, now we're all trained as anesthesiologists, anaesthetists, critical care docs, whatever it is, to be some degree of expertise in pain management. So we should understand the drugs and how to use the drugs. At what stage do you make a transition to call Padma or one of her friends to say, I now need those other tools to be brought to bear? Because I don't know how to subscribe the psychosocial support or whatever it is I'll get to.
I think identifying patients even as early as before they ever present for surgery, when they come to their surgeon's office for the initial visit, I think there are certain patients that could benefit from pain management expertise beyond what we all have learned as critical care intensivists or anesthetists in training. And those would be people who already take a high level of pain medication prior to surgery. Those are not those patients can potentially be, without modification or optimization, be very difficult to manage in the perioperative period. So in those kind of patients, we would want to engage specialists in pain management for that.
So when you go down the list of drugs preoperatively and they're having cardiac surgery, for example, if they start to list pain meds,
Right.
it should be a flag.
Yes, well, and especially with the amounts. We can debate the actual amount, but in our preoperative clinic, a morphine equivalent dose of 50 milligrams or more is certainly a red flag that this patient may have trouble with pain management postoperatively.
So when that happens at Duke, what do you do now if you do get one of those patients?
So now what we can do in our PASS clinic, perioperative anesthesia and surgical screening clinic, is by having enough lead time up into the surgery. We want to see those patients as soon as possible after they consult with the surgeon about surgery. We can refer them to our perioperative pain management clinic, which specializes in taking care of these at times incredibly complex patients, to try to avoid some of the problems with readmission, respiratory depression, overdosing that can occur following surgery.
And then, Padma, if your team, your specialist team, makes a decision to support said individual as part of their care package, they enter this, is it right, the perioperative pain care continuum? Mm-hmm. So you're in for up to 90 days, is that right?
That's correct, for 90 days after surgery.
So we're here with you from
We're
now.
walking the entire journey.
Okay, and with that brings a specialist team that includes nutrition, pain psychologists, physical therapists. It's a whole multifaceted, multimodal team.
Absolutely.
Now, if as part of that, so Annemarie's identified the patient, well done Annemarie, flagged them up, referred them to you, you've shown them lots of additional support and love out to 90 days. There's always going to be, particularly for thoracic patients, for example, there's going to be a subset of people who look that pain is going to be an issue for life now. Mm-hmm. So at what stage do you refer them as with a badge of chronic pain of some form for extra support? So
immediately after surgery, we're actually at the first visit after surgery when they come back to us, we're looking to see how they're responding to the post-surgical episode, and we start to educate those that we suspect may have persistent postoperative pain about the fact that this may be persistent, that they may have more chronic pain issues develop from this. So it's really as early as that we start to engage in the conversation that they may need chronic pain care, and engaging them with those specialists, encouraging referrals to set it up. The reason we do that is here, access into these chronic pain clinics is not immediate, and therefore it can take up to a month or two. Okay. So we prepare them in advance to say, you should get your referral in because you may need it. You may need this appointment, because we'll take care of you up to 90 days. But should it persist past that, it is chronic pain and you would need extra support.
I think you've shown us before some of the results. It looks to me like it's having a big impact. It looks like it's been financially highly effective as well. Is that your impression, Annemarie? I'm going to call you a user now, if you see what I mean. Is anyone, someone who's throwing up the red flags and referring them and then getting them back on critical care and hoping for that extra support? Is it a reality?
Well, I think when you look at it, it does provide value. If you look at patient outcome, there is probably no better patient outcome than ensuring the safety of a patient when you're talking about things like respiratory depression, cardiac arrest, readmissions, inadvertent falls, accidents related to the overprescription of these kind of medicines. The patient outcome is there. The cost, in my estimation, for to be seen by specialists is minimal by comparison. So I do think it is of great value.
So, Mike, we're pretty mean in the NHS when it comes to throwing money at things that we don't think produce high value. What's it like at Southampton? Do you get similar support? Or do you think you should get similar support?
I think we should. Until relatively recently, we've had, in comparison with many other institutions in the UK, very modest support for pain, although that is developing at the moment, and we've got some great new members on faculty.
So at UCL, I think we've been quite privileged by having a high level of interest from our chronic pain teams and acute pain teams working together, and Padma met some of our teams over there.
Fantastic faculty.
I think we're pretty well served where we are. We've been convinced it's value for money. It's hard to get the resources.
It's really hard, but I think we're enthusiastic to make that case. And actually, the development of the perioperative medicine team rounding after surgery is an opportunity to do that relatively efficiently, in that we're not necessarily asking for a pain team to go around and a perioperative medicine team to go around. We can attempt to combine the two and have one or two people providing the pain expertise into the perioperative medicine team.
Yep. Part of the problem we've had, you've spoken to Natasha Curran quite a lot about this at UCL, Padma, is once we're a bit like you were discussing, once we get outside this magic 90-day window, sometimes it's a 30-day window, and you kind of think, well, the acute hospital care deal is over, you're back into sometimes a different budget. With us, it wanders into our social care budget still at the moment. We're trying to change that in the NHS. But that's when the people start to turn around and say, well, that's a lovely idea, but who's going to be paying for it? Is that what you've seen as well, Mike?
Yes, we see. I mean, we don't have as much on tap in terms of long-term pain support in the community.
Yeah.
But certainly
we have less as well.
Yeah, more broadly, it is a challenge at the moment, but a challenge which I think, as an eternal optimist, that the recently announced changes in the NHS will help to overcome. So this clear move now towards accountable care organisations and the integration of primary and secondary care, I think is a great step forward.
That's the incentives, the motivations, and we're all trying to do the right thing. But when you have these so-called accountable care organisations, when you get a fee per head in the population to look after everybody, it becomes this changes in its position in the priority list.
Completely. I mean, the notion of what you've just described, so capitated funding, suddenly aligns everybody's interests in trying to spend the money as efficiently as possible.
Where are you at Duke, Annemarie, with regards to the accountable care organisations? So it's happening some places in the USA, is that right?
Yes, and it's happening with increasing frequency at Duke. Duke used to be in this fairly protected area of being a juggernaut in its region and not with a lot of accountability to costs. And I think many academic medical centers in the country had that same luxury, but definitely the landscape has changed. And when we look at whether to parse money to these kind of initiatives, we also have to think of the burden of disease. And I think in the U.S., to speak to Mike's point, the opioid epidemic is far more widespread and devastating than it has been in the U.K., and it seems a logical place to put some of these resources to avoid these tragic outcomes.
So Padma, from your perspective, reaching right out to the community, is that a hallelujah moment? It's kind of like that's where we should be.
Absolutely. I mean, making sure that we support this population, support this chronic disease process in a better way, and how we take care of these patients is critical.
So I'm going to switch gears, if I may, and you can bring me back to the opioid things. But in the interest of time, Annemarie, you brought up the subject of anemia, which we've discussed a number of times on Top Med Talk this year. And in particular, some of the great successes you've had at Duke with your anemia clinics. And in the discussions, we got to the point about sex discrimination when it comes to anemia, which is very increasingly commonly talked about. What's your attitude at Duke?
Right.
We'll loop back on what we mean by that in a second.
So one of the things we're talking about, is there an anemia threshold for men that is at a higher level than women? As you had stated before, we're all the same material. Many of us are all approximately the same weight. This just doesn't seem logical there's not enough variation to justify these kind of differences. And the World Health Organization has now seemed to have established one number, 11.5 grams per deciliter, around there, that would seem to apply to everyone. There is, but there are differences in men and women.
Just pull up for a second the 11 point, because 11.5 to me it looks anemic. Is that the kind of?
It is.
That's for the planet. That's for the world.
That's for the planet.
To say below that number, you need to be there's something going on that we can call anemia.
Well, I think one of the issues, obviously everything has to be put in context. You can't just throw a number out there to a global population. Yeah. That number means something different in someone who has just had a child versus someone who's had weight loss, night sweats, is 70 years old and has no other reason to have a blood count that low, a hemoglobin that low. So obviously these numbers are guidelines. They're not absolutes, but you have to start somewhere. It's important to pick a target and manage toward that target. If there's evidence to suggest that the threshold needs to be higher or lower, then that's why you take your protocols and adjust them.
Because the number that's being bandied around more in the United Kingdom, I think a relatively healthy population and a well-resourced country, a wealthy country, is more like 13 grams per decilitre or 130 grams per litre, a crit of 36. Are you familiar with those numbers, Mike, as being?
Yeah, I think those are common currency for us.
So where do you stand, because you've got an anemia clinic now, I believe, at Southampton. Where do you stand on the sex discrimination? Because we've touched on this before, but we were brought up at medical school having to remember the difference between the threshold for a woman and a threshold for a man. Physiologically, that's nonsense, isn't it?
Almost certainly.
Right. Okay.
I can't see a gender-based reason why.
With regards to oxygen flux.
In relation to oxygen flux, no.
But the risk with preoperative anemia, apart from there's a long list of risks that it brings, that hard to separate the chicken from the egg in this. But the very tangible risk is the risk of blood transfusion, isn't it? And you showed us data, Annemarie, from Duke, where you could look at your own data at Duke and give cut-off points for certain procedures to say if you don't get your preoperative hemoglobin or crit above this level, you're at much greater risk of transfusion. So that's our target, the operation adjusted. Were they sex adjusted as well, or is that just
They were
operation?
not sex adjusted, just done purely by the type of operation. And so what they learned is that the level at which people would be transfused varied depending on the intensity of surgery. Yeah. So someone undergoing a procedure where there's potentially more blood loss, like a revision hip, might get transfused at a higher hemoglobin level than someone who's getting an elective initial primary knee replacement.
And that's, I think, a smart way to construct a business case. If you've got a large electronic health record, you can go internally and say, well, we know this is our in-house level that's going to drive it. Now, but Mike, to knock that back to you, if we're looking at the population health benefits of perioperative medicine, is that a little bit selfish, if you see what I mean, as opposed to taking the opportunity to fix their anemia for the greater good of them for the whole of their life, as opposed to, I can avoid transfusing you? Well, does that make sense? This is the overlap between the immediate hospital responsibility for the procedure and the responsibility for life.
I think there's pragmatically, anemia and anemia clinics have been a way in for many hospitals around the whole notion of perioperative comorbidity management. Yeah. And the reason for that has been that the business case is very straightforward. You don't have to construct something more complex around reduction in complications or long-term health benefits, because the direct and indirect costs of blood transfusion are very substantial. If you can knock those down, it's a slam dunk. So I think people have gone the route of least resistance, but that's not to say there isn't a belief that it's probably in the patient's benefit as well.
During this session, I was looking up some of the stuff that's going on in the UK happening quite quickly, and I've noticed now there's an emergence of private clinics. In other words, people turn around and saying, anemia is common in certain age groups, in females in particular, and it can cause this long list of things that are going to affect the quality of your life. Why not take some ownership, in discussion with your physician and go and sort yourself out? Have you seen any of that happening in the US yet?
We haven't seen any sort of pop-up anemia clinics or anything. It sounds like an interesting business model, but at this point, it's having the discussion with the physician, and I think physicians need to take anemia seriously. I think for the longest time, it's like, well, you can get to that a little later, or that's okay, that's low for you. But okay, I think one of the important things as internists that have been difficult is sometimes reminding people that's not normal. We may see it a lot, a low hemoglobin a lot, but that's not necessarily normal. And the next question that should be prompted is why? And taking that opportunity, especially in the perioperative episode, to at least, if you don't work it up at the time, to get those sort of mechanisms in place to have that evaluated.
Is that, Padma, some of the literature suggests there may be a relationship between chronic anemia and how you respond to pain. It's on the list of the
early literature there. Yes, absolutely.
Along with the dietary issues we discussed and everything. Yeah. So, and it can contribute to depression, I understand. So lots of reasons why this routine could have a far-reaching benefit. So the final subject, because we're almost out of time, although we touched on very many other things today, but overlaps quite a lot with anemia, is diabetes. So very common, it would appear.
Yes.
Very common as you get to a particular age.
Yes.
Particularly common if the belt's getting a little bit tighter.
Yes.
I checked my
and
BMI.
a high percentage of people that don't even realize that they have diabetes.
I have my HbA1c checked by my wonderful general practitioner on a regular basis, and he always comments on how tight my trousers are and what my BMI might be,
Right.
and continues to remind me about the opportunities to stave off becoming diabetic. So if you're listening, thank you for all of that, which are healthy reminders. But you said it's incredibly common that people don't know.
Yes, very common. The symptoms of diabetes, if you will, can be a long time in coming. There's a lot of damage that can be done to vascular tissue, to eyes, to kidneys. I mean, it's a vasculopathy, and those things happen slowly over decades, and very, very few people, unless they look, can really notice. Now, that's different from someone who has an acute type 1 diabetes. That's a very different presentation. But for the majority of diabetics in our country, it's type 2, and it's definitely much more indolent.
So if you're over 45 and your BMI is up a bit,
yes,
it's worth taking a bit of ownership.
Yeah,
of
it's in the
finding
higher
that out.
20s, so we're not talking up a bit like a BMI of 40 or 50.
Okay.
We're talking about a small increase can put you at increased risk of diabetes.
And to give us some sense of how common it is, how many patients present, or do you think have presented at Duke? Because I know you did a survey of some 431,480-something patients at Duke from 1999 to 2013.
Yes.
How many of those were closet diabetics?
Trying to remember, I think it's around 16. Well, there were 16,000 diabetics, and so if you say a quarter of those didn't even know it, you're probably talking about anywhere from like 2,000 to 4,000. Just kind of roughing in the numbers for that.
So that's that number I often hear banded around. About a quarter of the patients presenting for more major surgeries don't know that they're pre-diabetic. Right. Is that number familiar to you, Mike?
Those sort of numbers. I mean, my impression is in the UK. So there's the known diabetics. There's the unknown group of diabetics, which is a similar sort of number to what you just stated. And then there's the sort of stress hypoglycemia group, who maybe yet again a different group.
Right.
And there's a feeling that those that do best are actually those that are already diagnosed.
Right.
Yes, I got that. So you showed us some data, Annemarie, about the relationship between in cardiac and non-cardiac patients between HbA1c and outcome, and that didn't show a very clear picture to me.
Not in the perioperative period. So if you look at HbA1c, hemoglobin A1c in these patients, both cardiac and non-cardiac, doesn't appear in the perioperative period to be an increased risk of mortality regardless of the initial hemoglobin A1c.
But if they became hypoglycemic, it did.
Correct. So in the cardiac surgery patient population in particular, it was a U-shaped curve that below a certain threshold of glucose, patients had an increased risk of mortality, and above a certain threshold of glucose, they were at increased risk.
And when I was sitting there looking at that, because I haven't, the paper's not out yet,
it's in press.
It's in the pipes, in press. This loops back to Mike's point, is one gets the impression that previously known diabetics get pretty damn well looked after. Their glycemic control is very good perioperatively, particularly if they're insulin dependent, it's superb. Mm-hmm. If they're non-insulin dependent, it's usually pretty good. But I get the impression that the unrecognised diabetics swing from being long periods of hypoglycemia and then slamming in with treatments that can push them the other way. Do we know if they're in there, those patients, or is your analysis not allowed to delve into that?
So our analysis hasn't delved into that level, but you can imagine, as you said, that some of these people are undiagnosed diabetics or people with poor glucose control at baseline, and you add the stress of surgery, steroids, some of the medications we give, and that puts them at risk.
No one's looking that closely for it.
No, not yet.
So I think that's what we should look into. No one's looking that closely, and then they find out their sugar's way off the scale at 2 o'clock in the morning, and then someone hits them with some insulin, and then it goes the other way. Anecdotally, do you get that impression, Mike?
Yes, and I think the patients are also ill-equipped to deal with it, because most diabetic patients are experts at self-management and can therefore contribute to the journey around the time of surgery, whereas if it's new news, I think it's a lot trickier for both patients and for care providers.
Excellent. So we had many other discussions today, including discussions about leadership, management, outcomes. We'll hopefully get a chance to talk about those on another Top Med Talk in the future. For those of you listening, don't forget to subscribe to our podcasts. You can find those on any of the regular podcatchers are available. Follow us on social media. Please check our website on a regular basis, topmedtalk.com. We usually embed some articles in there as well that you can follow, various different links And you can find out more, go to the bottom of the page about the Morpheus Consortium that we've been referring to. We're going to be popping up at a number of different meetings, including the upcoming EBPOM, Evidence-Based Perioperative Medicine meeting in London in July. Ladies, will we see you there?
Yes, you will. Well, looking forward to it.
Excellent. Annemarie, you coming?
I am not coming this year, but I'll be at the one in Chicago.
Chicago. So you'll see Chicago in September.
Yes.
Mike, have you enjoyed your couple of days here?
Really excellent. I've really enjoyed the discussion. They've rightly worked as hard, but it's been some really fascinating discussions, the case-based discussions, comparing and contrasting the UK and US experience. I think has been very interesting and generated quite a few new insights for me.
Yes.
And I think we're learning in every conversation.
Yes.
So thanks, everyone.
Thank you.
Thank you.
Thank you.
Top Med Talk.